In the meantime, I'll introduce myself. If you haven't been part of the conference so far, I'm Chris Laxton. I chair the Advancing Excellence Collaborative. This session is on inequalities in the post-acute long-term care workforce and how to address those. We are running a little bit short on time, so I'll ask that if we can keep this panel a little bit tight, we can probably catch up a little bit of that time. But Audrey, I will hand this over to you, and looking forward to the discussion.
Okay, thank you. Do our participants on?
We're missing Angel still. Looks like. Do we have Lori? Where's Lori? I thought
I'm here.
Yep.
Okay, hey, there you are. Okay, so we got Lori, Janet. Where's Faith?
Faith is there.
I'm here.
Oh, you know what? Let me expand my screen. I'm not seeing everybody. Okay. All right. So yeah, we are just missing Angel. And what's the run order for? Where does Angel fit?
Angel
Audrey?
fits. She's second. She's after Janet.
Okay.
I saw she just emailed our group, Audrey, so I would think
Oh,
she's,
good. Okay. Okay.
however, she's probably not, in an office or something like that, but we'll just hear from her how we hear from her.
Yep.
Yes,
I just
We are live. Oh, okay. Guys, we're live.
We're live. Okay.
Oh,
Apparently
live.
so. I thought we were going to be in a, okay.
well, that'll make for an even more interesting
Yeah.
symposium.
Yes, exactly. Are we ready to start?
Yeah, I suggest you get started, and as soon as Angel joins, you can fit her into your lineup.
Okay. All right. Well, welcome to the second panel, which is going to focus on staff. My name is Audrey Wathen. I'm with the New Jewish Home in New York City, and we have an amazing panel to really broach the topic of staff, which really permeates through a lot of the conversations that we're going to have over the next couple of days. I'd like to just take a second and have each of the panelists just tell you their name and where they're from, and then we're going to start our presentation to you and discussion with you. So Janet, would you like to just start with telling us who you are, and then we'll go to Lori and Faith and Angel if she has joined.
Hey, thank you very much, Audrey. My name is Janet Kaufman. I'm a professor of health policy in the Health Workforce Research Center for Long-Term Care and the Institute for Health Policy Studies at the University of California, San Francisco.
Okay, thank you, Janet. Lori?
I'm Lori Porter, and I am the co-founder and CEO of the National Association of Healthcare Assistants, the only national association for CNAs.
Thank you, Lori. Faith?
Good afternoon. I'm Faith Wiggins. I'm the Director of Long-Term Care Programs at the 1199 SEIU Training and Employment Funds. Happy to be here.
Hey, thank you, Faith. And we have one other panelist who's having a little trouble dialing in, but as soon as I see her, we will also introduce her to you. As we prepared for this segment, we tossed around a lot of ideas about how to bring this forward. And as you can well imagine, we had a lot of deep conversation and really serious conversations about the whole topic of staff and staffing and how do we do that. And we decided that we would start by giving you some information, but each of the panelists who you are going to hear from today are really going to try to bring you, what is their story, or what have they heard and what have they learned. And so we really want this to be information that sparks conversation, that raises awareness even more, and really incites us to action. One of the things we said is that we have talked about this topic for years, and we're talking about this topic again. So how do we really take some steps forward in this environment and make some real change? So I'm going to ask Janet to start with some information that I think you'll find incredibly helpful as we launch into this topic, and then we will move on to our next presenter. Feel free to put information in the chat if you have questions or comments about any of the presentations. Thank you.
Thank you very much, Audrey. I will try to be brief because I think a lot of the information I'm going to present on the slides really recaps information that's shared previously today. And so I think we can move through it quickly to set the stage for the rest of the session. Next slide, please. And so I think, you know, most of you, practically all of you on this call know this, but it's worth, I think, kind of reminding ourselves about who the workforce is in long-term services and supports. That's the term that our workforce center tends to use as opposed to long-term care. I think key here is that 38% composed of nursing, psychiatric, home health aides, and 23% personal care aides. So if you add that up, that's 61%, 6 out of 10 in the workforce are in these frontline worker jobs that are often low paid and incredibly demanding, and a much higher share of folks in these jobs than we'd see in other places in the healthcare sector. Next slide, please. I want to first talk about the financial vulnerability of long-term care services and support workers. And this comes from some work done by my colleague Uli Munk that was published in Medical Care Research and Review earlier this year. And no surprise to anyone on this panel that workers in long-term care earn low wages. What might surprise some of you is that these wages are lower than those of folks in other parts of the healthcare industry. People who work in long-term care are also more likely to be divorced, separated, or widowed and people working in other parts of the healthcare industry. So they're much more, excuse me a second, dependent on their incomes for the financial well-being of their families. They often don't have or they're less likely to have a second income in the household, and thus more likely to experience poverty and more likely to depend on some form of public assistance, be it Medicaid, food stamps, children's insurance program for their kids. As Dr. Grabowski has shown us, they're also more likely to be foreign-born, Black, or Latinx. Next slide. It's also important to understand that the racial ethnic composition of the workforce in long-term care changes as you move from positions that require the least level of formal education to a higher level. So here I've plotted 4 of the largest occupations: personal care aides, nursing, psych, home health aides, LPNs, and RNs. And if we focus, let's just focus a minute on Blacks. You know, Blacks are over a quarter of the personal care aide workforce, over a third of the nursing home, psych, and home health aide workforce, but only less than 20% of RNs. And you see some similar patterns for Latinx. And so that even within the nursing home industry, we have this imbalance where folks who are, you know, often running nursing homes, serving in leadership roles in the facility or the home health agency, do not reflect the diversity of the folks who are providing the bulk of the care. In other words, this is an issue not just at the absolute highest levels in long-term care facilities. As the previous speaker pointed out, it's an issue day to day in nursing homes. Next slide. And this one is just sort of a ground conversation we've had previously about the differences in the racial ethnic diversity of the workforce and the population that uses long-term care. So here I've got the long-term care, long-term services workforce on the left and the population age 85 years or older on the right. So this is not necessarily folks who are at any given point in time using using services or in a nursing home, using home health. It's just the population that's most likely to use those services in some fashion at some point in time. And I think the key takeaway here is to look at the sort of golden bar for whites. So about 51% of the long-term care workforce is white, but 82% of the population years age 85 or older is white. So we're in a situation where we have a very racially ethnically diverse workforce caring for a population that's predominantly white, and that brings with it, as Dr. Hrabowski mentioned, all the perspectives, prejudices, and attitudes that they learned when they were young. And I think that's certainly one of the sources of the challenges that our Black, Latinx, and Asian CNAs and other workers face. I'll stop with the slides now, and then want to just briefly share a little bit about my experience. When I was first asked to tell a story, I thought, well, what can I say? I don't work in the industry. I just study it. But then I realized, well, yes, actually we do have family experience. And I'm going to focus on my maternal grandmother because she's the one who spent the most time in long-term care. So up until age 95, she lived independently. First was my grandfather, and then after he passed away, lived by herself in an independent senior living community. Well, at age 95, she fell and broke a hip. And not surprisingly, after breaking her hip, she had a short stay, Medicare funded nursing home stay, a short-term Medicare home health. And that time she was able to regain some mobility, but really couldn't, be, totally independent. So after much discussion and a little bit of the primary care doctor playing the bad guy, she agreed to accept a personal care aide in her home. And that worked for 4 years. She had a Latinx, very lovely woman who came to the house 2-3 times a day to help her with homemaker services. But then at age 99, she fell again and she broke the other hip. And this time she didn't bounce back so well. And so after the short-term nursing home stay, we made the very difficult decision to place her in long-term nursing home because none of us could really find a way to live with her full time and take care of her. And none of us, quite frankly, really had the skills to do things like bathing that she needed. And so that was hard on all of us. And I have to say, I think sometimes we were hard on the staff. Just think of it, here I am, a professor. My mother's a retired teacher. One of my aunts is a retired nurse practitioner. So we're kind of used to being, a little exercising a little authority and thinking we have a little authority and loving grandma fiercely. That I am sure that there were times when we came in and found out grandma had not had her diaper changed when she got to the point that she couldn't even walk to the bathroom with help. When we found out her hearing aids were not in, that her food hadn't been cut up. And I'm sure that there were times we were not very polite to the staff. And I think we were so laser focused on grandma that even though we knew they were working hard and overworked, we were probably a little pushy. I'm sure we were a little pushy. And as I look back saying that, I mean, I think, I think in some ways that's understandable, but I think, family members who from their perspective are doing absolutely what they should do to take care of their elder can make things worse. And especially if we don't work hard to treat people with respect. So I know we need to move ahead. So sort of 3 things family members can do. Number 1 is just be respectful. Be aware that the staff is often overworked and they're not intentionally neglecting your mother, your father, your grandparent. It's certainly okay to ask for things to be done, but be respectful, empathetic. Secondly, and this is probably the hardest one, is to be willing to call it out when you see other people speaking inappropriately, making racist remarks, anti-immigrant remarks. Let me tell you, it's a hard thing to do. It's much easier to kind of bite your tongue or pretend you didn't hear. But I think I'm inspired by Dr. Hrabowski to say, we need to call one another on this stuff. And then thirdly, I think for all of us as family members to just be educated about the economics of the long-term care industry and to do what we can to advocate for better resources so that CNAs and others have what they are paid a fair wage and have the support they need to do a good job. I'll stop there.
Okay, thank you, Janet. One of the comments in the chat was that this is such a sadly common story where you see the health of a person decline over time and the family step in. I think what's interesting about what you were saying is when you marry together sort of your personal story with the data, and I think about, you know, if the workforce are primarily people of color and the family is pushing to, you know, get the level of care that they think their loved one should have, how hard is that dynamic, and how easily can that complete dynamic be misunderstood for all kinds of external factors, but it's ripe for misunderstanding and misinterpretation. So I think that both, you know, I think your story is very powerful, and the data that you presented really link with that to help us understand what that dynamic could look like. Good, very
Okay.
good. Thank you, Janet.
Thank you, Audrey.
Sure. Lori, I'm going to
Yes.
ask you to address this group. I just have to say to everyone before Lori speaks that when we were prepping for this, I was so inspired by Lori's passion for this work, and I'm sure you will too. She just lives this and breathes this and inspires us. So Lori, there's the segue to you. I would love for you to just share your life and your work and a story with us.
Very well. Thank you so much. And thank you for the pulpit. I don't get it very often, and CNAs don't get it very often. And one thing, ethnicity, one thing all CNAs have in common, no matter their race, is their socioeconomic status. And today, Dr. Grabowski's right. I'm not going to let anybody else off the hook in this profession, nor the people that surround this profession of professional organizations. I've been serving CNAs for 26 years. Last night at 1:30 a.m., I was on the phone with one of our members who only got to touch a resident one time in her entire shift. And that time was when she held the phone to his ear and his hand with her other hand while his daughter said goodbye from the window. And Sherry had been there 8.5 hours and only was able to touch that man one time. And yet she stays. She's been at the same building 25 years. She's had 3 quarantines where she has exhausted every penny of her vacation and her sick pay, and yesterday tested positive for COVID-19 and has no more way to support herself after giving 25 years in the same facility. We're not even rewarded for tenure. CNAs can no longer, we are short 174,000 of them today, and they need your help. I need your help to continue to support them. And if I don't, if NACA doesn't, who will? I got 7 members living in their cars with children. Tell me how a woman who's willing to take care of someone else's mother has to live in their car. Please chat in if you think that this is right. We all say we don't, it's lip service. I was on with CMS 7 months ago. Oh, Lori, we know CNAs are the backbone. That was what I was told in 1980, the first night I worked as a CNA, that I was the backbone. And 40 years later, that's still all you got for us? Is we're the backbone? The value of a CNA is equal to the value of a resident in this country, and that is very little. Very little. I just found out the state of Oklahoma gets $150 a day to take care of a resident. You tell me how person-centered care is possible on that, or to pay a care force. CNAs are not workers. They're highly offended when you take certification away from them to call them resident care specialists or direct care workers is what many of you in your academia and various things have resorted to calling them direct care workers, and you have no idea what that does to them. Money until COVID was never the top of the list. It was respect, admiration, lifting them up. They're willing to do the heavy lift, but can we not find a way to treat them better? We have a united way in this country. We need a united way CNA, where every corporation and every academia that makes money in the long-term care, LTSS, is giving to help this group of people more than anywhere else in our workspace. They cannot keep suffering on the front line, and us, I don't need any more meetings. I don't need any more symposiums. I've lived this every day for 40 years. I've been the CNA that couldn't get to the resident in time. I've been there when their parents showed up when it was an 18-year-old girl in a vegetative state, and it was my fault. She was laying in urine for hours and hours. It was my fault. Or at least I got written up for it. So the establishment said it was my fault. Now, I was fortunate. I stayed single most of my young life. I didn't have children. But I can tell you, I don't know how I'd have made it if I had have. If I had had children, I couldn't have done it. We have to find a way to help these folks. And they don't know that you care about them. They don't know you. They don't know Dr. Grabowski. All they know is lips. All they know, oh, Angel's here. Thank God. I'm going to shut up. Audrey, let's go to Angel, please.
Okay.
Lori, again, and so now you can see why I said that she is so passionate about this. And I think, you know, Lori says some tough things that we all need to hear. And thank you for having the courage to say them and to calling us to action on this. Thank you, Lori.
Thank you.
I see that Angel has joined us. Angel, you are on a call with 51 participants and the panel, which you are part of. And what we'd love for you to do is to introduce yourself, tell us your name and what you do. And if you could just take a few minutes to share a couple of things that have impressed you or really touched you as it relates to staff in long-term care.
Okay.
Hi.
Hi, you guys see
Nice to
me?
see you.
I'm always in the car, but I'm parked. Okay.
I want everyone to realize that we have the luxury of sitting in an office or at home, and Angel is in her car. She's probably working today. So,
Oh, yeah.
so tell us your name and what you do, and then if you could share a few things with us that you think you want us to know today.
Okay. Well, hi, everybody. My name is Angel Jackson. I'm a CNA. I work for, I work for Coronado Healthcare, and in the nursing facility. I also work for hospice as a CNA and a chaplain. So I have a lot of roles, so I'm always busy. But I love what I do, and I've been a CNA for 23 years, and I worked in different facilities, different like hospice, hospitals, and everything. So, and I've worked in long-term care for a long time too. So, you know, I know all of the aspects of it. So I just wanted to talk to you guys today about the some of the things that, you know, as CNAs and healthcare workers that work in the long term or the hospital settings. I just wanted to talk to you guys about, you know, sometimes as Black or African American workers or, you know, CNAs, that, you know, we may get, you know, feel a little bit discriminated against sometimes. And a lot of times, you know, being in it for this long, it's like, oh, that's just how it is. But sometimes it feels like, you know, it brings down our self-esteem pretty much. Like, okay, this is how we got to do, and this is how we have to be. And sometimes it makes us feel like, you know, maybe we can't come up to the level of our other coworkers that are Caucasian or Hispanic or other races. So, sometimes we deal with feeling like we can't, say what we need to say without feeling like we're being insubordinate or anything, or they might feel like that we're aggressive or anything like that when we're just trying to express ourselves. And, it just makes us feel like, like it's a fight. And it shouldn't be that way to express ourselves. It shouldn't be a fight, but that's how it is. And it, sometimes it makes us feel that way. And we shouldn't have to feel that way. We should all feel like we're on the same level. And it feels like, a lot of times we have to work harder than our, Caucasian or Hispanic or other races coworkers. And, we have to just be more than they are. But then when we doing more than them, it's still equal or less than, so, I just wanted to talk about that, and maybe, ways that we can kind of change that and get everybody to understand that's how we feel. And we just want to feel equal to everybody, because, we all are here, working as a team. We're supposed to work as a team, and as a team, we're supposed to respect one another. And that's what it all comes with. So, a lot of times the other coworkers that are not Black or African American feel like, they may not feel like they are discriminated against. It seems like they're so systematic of how things are and how they were, that it's like, they feel like it's what do you mean? I have friends, I have family members that are like, I'm not, discriminated against you, or I'm not trying to make you feel that way. And they're probably not, and then there's some that are, but that's something that we deal with. And it's, it just kind of makes us feel less than, so that's my whole thing on it. And there's a couple other things I wanted to touch on too, with the level of respect and, going up to like a higher position, or, like the lead CNA. A lot of us are not lead CNA. There's a lot of us that are, but then there's a lot, there's not as many as our Caucasian workers that are the lead CNA, or, they would give them an opportunity to be in a leadership position. So it kind of makes you feel like that you can't even get there. And we want to, and a lot of times we have to empower ourselves to get ourselves out of it, to get out of feeling that way, to feel like, oh, we can just settle for less, or, if they make us feel this way, we just gotta, shut our mouth and not say anything, so it's a lot of that. And a lot of times they say, oh, it's just the CNAs. And I remember somebody was saying, well, because they're just CNAs, and the nurses don't have to deal with that. Nurses do, doctors do, that are of color. They have to too. And even our president, Barack Obama, he had to deal with that. So it's far beyond us too. But we're just talking about CNAs right now. So that's something that we deal with, and it would be nice. It would be good. It would be respectful, and it would be feeling like we're working as a team if we can all understand one another and have respect. So that's where I feel about the racial thing in the workplace. So, and I'm trying to think what else. Oh, and even when we're like, if we're working together, like it might be a group of us that are all Black or African American that are working, on the same floor or whatever. We feel like we can't express ourselves, or we have to like, oh, let's be quiet. We don't want to, make them think that we're clowning around or anything. We're still working, and we work hard. And sometimes, you just gotta take a little break, giggle a little bit, and then go ahead and do your work. But it seemed like we have to like oh, what you clowning around? What are you guys doing? We're gonna have to break you guys up. It's a lot of that. Like, why would you break us up? We work as a team, you know? And so you're gonna break up our team, you know, and so we can get with another team member, but why are you breaking up our team? So it's a lot of that too. So it just seems like we, you know, we gotta like put our voice down because we're, you know, us trying to be heard is aggressive, you know. So that's what it seems like to me, you know. To me, it seems that way. And I have a one of my good friends. She's a part of the NACA team too. Me and her, we facilitated together, and you know, we have different views on things. You know, especially with the whole Black Lives Matter thing. That was a big issue this year in the workplace. And you know, I respect her on how she, you know, feels about it. You know, you don't understand about it. I would like to educate you on it, and I try to, but she, you know, strongly believes a certain type of way, and I can't even blame her for that. I love her to death, you know, but that right there, I would hate for that to be the reason why we're not friends, because a lot of people have done that. You know, I would hate for that. So if it's just like, well, I respect how you feel and you respect how I feel about the whole situation, and that's what it is, you know. So I'll just get to the point if she try to bring it up, because I don't try to bring it up because I already know you feel differently, and I'll be like, well, you know what? We're not gonna talk about it today. What? How are you and your family doing? You know, I just have to do it like that, you know. But to me, it's all a level of respect, you know, respecting one another, and you know, respecting each other's views. And you know, I really learned that as, you know, because I'm a CNA too and a chaplain. I learned that as a chaplain with the whole religion thing. You know, we can't be biased. You know, you can't say, well, I'm Catholic, or they'll be Catholic, I'm not Catholic, but I still have to help them to get to their spiritual way, to help them to cope through their dying process. So it's like, you know, it doesn't matter if they're in the science of the mind, or the, you know, Catholic, Methodist, or whatever. I still have to have that respect for them and help them to get to that level to where they can feel comfortable before they pass. So that made me see a lot of things, you know, how, you know, people are different, and how you have to respect it. And, you know, and it's not even like you're going with it. It's just that you're respecting, you know, their wishes and how they are. And we're all different. Everybody's different. And you just have to look at it like that. And once you look at it like that, then you can respect that person, and then we can all be in harmony, you know. So
I think that's a really good example of, it's one example of how to put things aside and focus on what's important. You know, at that moment when you're a chaplain and you're, you know, supporting a family or a dying person, you know, people don't really care what color you are or what religion you are. At that point, it's about someone's life, and it's about respecting a process. So I think that that's a really good example of, one example anyway, of how this is possible for us to do, if we choose to do so, and if we think about situations like that. I want to give Faith also some time to talk to us from a different perspective. But before I do that, I just want to go back. Lori, I don't know if you're looking at the chat or if you can see the chat, but there's so many people who are thanking you for the comments that you made and the passion that you know, gave us your comments. And Angel also some comments thanking you for, you know, speaking out and letting us know. You know, I think it's so interesting that whatever conversation we're having, the same things come up. It's about respect, and people are just being misunderstood. It's almost like people should wear a t-shirt, please understand me, because we you know, we walk around our workforce, and it's unfortunate that people are feeling that way. And Angel, I think you said something right when you first started talking about people coming up to, you know, we work in such a hierarchy that we're striving to go up. And it's good to be up and it's bad to be down. And you know, I've often talked about we need to draw the charts for our organization as an inverted triangle, so that the apex is at the bottom, and the people who are making decisions are really not the most important people. It's the people who are taking care of the people we love. So, so let me move to Faith. And Faith Wiggins, who I've known and worked with before, has a perspective that we also thought was very interesting, because it starts to get into, well, what do we do about it? And what are some of the things that we can do to help mitigate some of the things that we're seeing in the workplace? So Faith, I'll turn it over to you.
Thanks, Audrey. And
Sure.
to my co-panelists, Janet, Angel, Lori, I mean, our time together has been really inspiring. We were asked to share a story, and I'm just recognizing, one, I'm really glad to be in this space, but it's an uncomfortable space when we're talking about racism, when we're talking about difference, and trying to really out those issues so we can come to some change. So just a little background in my story. I'm blessed in that my mother is 85. My father passed away very quickly 20 years ago. So I have not had the experience of really hands-on caregiving and parenting. But as a kid, I grew up in the late 60s, early 70s in Mayor Rizzo's Philadelphia, and was often, when the Catholic school was out, chased home by high school boys with their dogs while in elementary school. And thank goodness my older siblings, one had each hand as we ran, 7 blocks to our house for safety. They never caught us, but these aggressions that, while I experienced them, were very horrific, it really pales in comparison to the day-to-day lived experience of our frontline home care and nursing home workers that are dealing with these challenges of aggression, abuse, and the anxiety that it creates. In that, just to share a little bit before you go to the next slide. So TEF, the Training and Employment Funds, is not the labor union. We are a jointly governed organization governed by the labor union and the healthcare sector, with industry leaders on our board. Some of them are here in this conference. And our work is across hospitals, ambulatory care, nursing homes, pharmacy, and community-based organizations. I am here not as an expert in racial diversity, but as a Black woman bringing my lived experience and the knowledge that I have over my 25 years in home care, and more recently working with nursing homes and CNAs. That's really what I bring to this conversation. So hopefully it'll be relevant in some way. You can go to the next slide, please. So just a little bit more about who we are at the Training and Employment Funds and our work in long-term care. We have over 1.5 million workers, which includes over 350 employers in downstate New York and New Jersey that have home care workers and CNAs as part of the workforce. And our work is really about providing access to education, skills training, and employment support. And we've been fortunate over the last couple of years to have funding through a CMS waiver to provide a workforce investment organization exclusively for providing retention, training, and recruitment support for the nursing home and home care sectors. And over the past 2.5 years, we've had 80,000 completed trainings in New York State. So, we're really trying to do our work. And now with COVID, we're also mitigating the digital divide, just another form of inequity in our systems, because in this space, without access to a device and to Wi-Fi, it's really hard for us to do our work in terms of access to training and skill building activities. You can go to the next slide, please. So the workers we serve are extremely diverse. Over 50% are immigrant, 40% speak a language other than English as their first language. 71% are Black or Latinx, and 78% are female. So our workforce services must address our community and provide wraparound support. So we also have benefits like healthcare, childcare, employment support, tutoring for people who are in programs, and we embrace the principles of adult learning and popular education so that our work really does center around 3 core themes. And I'm really happy that I heard Angel speak to them. And it's communication, understanding, and respect. Go to the next slide. So what I hope to share with you over these next few minutes are just some examples of our work to address the diverse community of workers and learners that we serve, and technology permitting and time, there'll be a short 3-minute video at the end. So in the Bronx, it's the borough in New York City where over 50% are Latinx, 25% are below the poverty level, and 41% are low literacy, and it has the highest mortality rate in New York State. So several years ago, we set up a multi-healthcare sector program to address the needs for culturally competent workers in the Bronx who suffered disproportionately from preventable diseases such as hypertension, diabetes, and hopefully avert the need for long nursing home and home care services. But we also recognize that college access was a barrier. So we partnered with the City University of New York, who provides the public higher education system, and we partnered with our Bronx healthcare providers across the healthcare continuum to build a program that would provide access. And I'm happy to report that we have dozens of Bronx natives, mostly who were unemployed or underemployed, who are now working as home health aides, CNAs, registered nurses, LPNs, and providing care based on this work that we did over several years. Next, please. So I loved this slide. It's old. It was a look at the breakdown at one segment of our English for speakers of other language programs. And we were seeing, what are the languages that we're serving? This was several years ago, and it's just a slice of the 1,500 ESOL participants we serve per year. And it reminded me that when we looked at this and dug deeper, we found that we had lots of folks in the pipeline who had been professionals in terms of medical doctors and nurses in their country of origin. So what did we do? We created a program that helped those folks move into higher levels of work in the healthcare community. But again, starting where people were and to make sure that they were making progress, and we were celebrating the diversity of our second language speakers. Next, please. And again, in ESL, what do? We have to make learning fun because learning language is not easy. So we provide a contextualized healthcare curriculum in our ESL program, but we also do project-based learning activities to make sure that we're embedding conversations that are important to the community. So in this case, this example, just for a few minutes, actually less than a few minutes, we looked at Motown because it was an opportunity to talk about racial history in America while our students studied Motown. Next. So each class had a different topic ranging from the Motown sound to Stevie Wonder and the Supremes. Next. Each class looked at a song and also in this celebration sang a song and had education related to their theme at different levels. Next. This is a low intermediate class that studied the birth of Motown. Next. And if you see, the language was really appropriate to the class and where folks were with their language skills, but also brought up interesting facts in terms of the culture in the 60s and 70s. Next. They also learned the significance of Detroit as a city where many Black Southerners migrated in the early 60s, and where the Motown, word actually came from. Next. And a higher level class, this is our advanced class, focused on civil rights, which is a really important dialogue when we're talking about understanding diversity and difference. Next. As you see an example from this curriculum and content, the language gets a little bit deeper. The social context recognizes that racial relations still have not made adequate improvements. And our goal in this class was really to create a safe place for the ESOL students to communicate, understand each other's experiences, and respect that while coming from different places, they really do have lots of common ground. So in these next few slides, which you can really just roll through quickly, you'll see the classes coming together in the Union Hall, celebrating, singing songs, and sharing what they learned with each other in this celebration. You could stop there. So the last example I'm going to provide is our Language of Care program. This was designed for CNAs to learn the language of their residents. We created content for workers to learn Mandarin, Russian, and Spanish in this program, which rather than have me talk about it, if technology cooperates, I'm going to show a really short video about it. Okay, the sound is not there. Okay, I don't think we have sound, but if this isn't working, given that we are a little bit behind, it's something that perhaps we can share with folks after the fact. But in short, it goes into several residences, and you're hearing from CNAs about their experience with the curriculum, and also shows you residents and how joyful they are as a result of having workers in the residence be able to speak and share their culture in terms of not only language, but music and other rituals. So just what are the solutions? What do we do? There's so much that needs to happen, as we've been hearing and participating in this afternoon. So given the many aggressions and microaggressions that the frontline workforce experiences, and I think these things have been heightened in this time of COVID, we also understand that self-care is really important. You can go to the next slide. We've moved a lot of our, oh, it's missing. Okay, let's speak to it. We moved a lot of our skills training out of the classroom and onto Zoom and other learning management systems. But again, the digital divide is still real, and many don't have access to internet. We've also put together courses that can be accessed on a phone to learn about grief and loss, understanding depression, trauma-informed care, and dealing with anxiety to help frontline workers deal with the mental and emotional challenges that are going on now. So in closing, while the 1199 Labor Union, our sponsor, they have a very long history of working to address racial, educational, income, and other inequities in our community and in our country. In this photo, you see Malcolm X, and that's Rosa Parks and A. Philip Randolph at a 1962 rally supporting poorly paid Black, Hispanic, and Caribbean hospital workers that were trying to get recognized in the local 1199, then named the Drug and Hospital Union. And this is in front of what's now the Brookdale Medical Center. So we believe this was the only time that Malcolm X actually identified himself with a labor union. And in this crowd, he's in front of a sign that's reading, Negro and Puerto Rican communities support Local 1199's fight to end exploitation. So we're still fighting, and it's time for all of us to continue to work together. And I really appreciate the leadership of the AELTCC for bringing us together to engage in these very important conversations to build our communication, our understanding, and mutual respect across our work. Thank you very much.
Thank you, Faith. I know that we are running short on time, but I want to do two things in 1 minute. First of all, I want to thank the panelists, the information, the emotion, the passion, the solutions. I think is exactly what we need to be talking about when we talk about staffing. So thank you all. It's a pleasure to work with you and to bring this information to the forefront. If there are additional comments, please put them in the chat. That was 30 seconds. In my last 30 seconds, I want to say, I can't ask this panel to do something I'm not willing to do myself. So I just want to say to you that we all have to continue looking for solutions. In 2008, in our organization, we sat around the table and said, how are we going to bring people who are really struggling to just get out of high school and into a health career? And from that moment until this one, we have identified over 800 students in the New York metro area who have gone through a program of introducing them to health careers. Many of them are CNAs, and we're very proud to make that connection. But it's just one thing. None of us have all the solutions, but put all together, many of us have a lot of the solutions. And I just want to thank all of you for the stories, for the information, for the solutions, and I'll turn it over to Chris.
Thank you so much, Audrey, and thank you to all of the panelists for sharing your insights and your on-the-ground experience. I don't know if Angel can still hear us, but your heart is huge, and we could see that with everything that you said. So thank you so much. And to Faith and Lori and Janet, again, all of your contributions are terrific. I feel bad that we've had to stop this and cut it short and move on to our next panel, because you clearly have so much more to share with us. And the only thing I'd say is invite you to join one of our work groups tomorrow. We have a work group focused on staff, and we'd love to hear more from you at that point. That this is where we come up with the solutions. So it'd be great if you could join us. So with that, we'll end this session, and we'll move on to our last panel, which is the leadership panel. The link has been put into the chat. And with that, I will thank you all for your contributions and close this room. Thank you.